and thank you for the invitation. So, lecture of today is Induction of Autoimmunity. Well, in some situations, pathogens induce autoimmunity. Or should we say that in some situations, pathogens just show up in autoimmunity, making advantage of the situation. Less than 10% of all multi-infectious cases are officially reported, diagnosed. And it's often difficult because symptoms can be different. Can have different infections, different strains, even different co-infections. We need to choose the correct lab analysis. And the symptoms we see in multi-infectious disease often mimic the symptoms we see in other disorders or the symptoms we see in autoimmune disorders. So, we develop an immune response, and this same immune response sometimes targets our own tissues, turning out to autoimmunity. Now, if we compare multi-infectious pathology with autoimmune pathology, we see a lot of similarities. We see in both situations the pathology is multifactorial. Many systems are involved: immunity, gut, detox, mitochondria, and so on. Often we see similarities in causes and contributing factors, and we often can use the same treatment options. Now, let's analyze our immune response in multi-infectious disease, and let's focus on immunity. I like to compare our immune system with a well-trained army. Just as in an army we need good organization, good communication between soldiers or immune cells. And this is mainly how our immune system is organized in case we are attacked by an, let's call it an invader. Well, antigen-presenting cells, I don't know if there's a pointer, okay. Antigen-presenting cells capture the antigen, the invader. They engulf and break down the antigen in different fragments, and one protein fragment will then be presented to immature T cells. We call them immature T cells because they have never been in contact with some antigen before. Now, based on this protein fragment that is presented, a matching receptor will be produced. From then on, there is further and further and further organization of our immune response, a lot of communication between the T cells, and T cells get educated to manifest an immune response when they see this part, this fragment. Now, a good immune response is a balanced immune response between Th1 and Th2. Th1 is our cellular immunity. It's the immunity that targets intracellular bacteria, viruses, even cancer cells. Th2 is how we produce antibodies. And so often we have a good balance between Th1 and Th2. I will go back to the previous slide to show you Th1, Th2. And the regulatory T cells are very important because they keep this in balance to make sure that we don't have, for example, an autoimmune response or a response completely out of balance. Now, let's define autoimmunity. Autoimmunity is an immune response against our own healthy cells and tissues. Any disease resulting from such an aberrant immune response is what we call autoimmunity. Now, let's see what we can find in the literature First of all, chlamydia. Chlamydia is often triggering rheumatoid arthritis. We often find chlamydia in joint tissue. Now, chlamydia is usually a reactivating infection, but in few situations we find chlamydia in the ticks themselves. Other publications show a link between mycoplasma and autoimmune diseases like arthritis. But there's much more literature. We have a study published in 2000 where nearly 40% of patients diagnosed with MS test positive for Borrelia. And also many studies show links between Epstein-Barr, CMV, viral infections, and development of MS and lupus. So many links in literature between pathogens and autoimmunity. Now, let's find a possible reason for that. And if we detail our immune response, once again, we could consider a mechanism that could explain this reaction. And this mechanism is called molecular mimicry. And molecular mimicry means that the protein fragment that we present to our Th immature cells, well, this protein fragment might closely resemble to self-proteins. And in these circumstances, our immune system will not only be activated against the pathogens, but also against our own tissues. Molecular mimicry. Now, as I told you in the introduction, it's a multifactorial problem we discussed today. Multi-infectious disease and autoimmunity. In both situations, immunity is disturbed. We have a lot of inflammatory cytokines. It's one big inflammation in both situations. And often we see gut dysbiosis, hyperpermeability, and food intolerances. Hormonal imbalance, disbalance, very common. Brain function, often impaired. And people usually suffer from fatigue and cognitive problems because our mitochondria are damaged in both conditions. In both situations, we have a lot of free radicals. The free radicals, they damage our mitochondria, and as a result, we stock less ATP energy. And never forget, in these kind of circumstances, our own detoxification system we have is disrupted. So all toxins and heavy metals that we normally should eliminate, they accumulate. And if they accumulate, they will mainly accumulate in our brain and cause more neurological problems. But we will detail this further in my presentation. Multiple sclerosis, MS, is probably one of the most common autoimmune neurodegenerative diseases. We have antibodies against the myelin coating surrounding the nerves, so there is progressive demyelination. Thank you. So let's say that the electrical impulses from nerve cell to nerve cell are decreased, finally leading to a disruption in messaging from brain to body and inside the brain. So primarily, we have in MS a situation with many cytokines. It's one big inflammation. We have oxidative stress causing damage, and also damage to the cells that make the myelin. The oligodendrocytes, they make the myelin, and they also got damage. It's the situation where the blood-brain barrier gets leaky, so T cells gain entry to our brain and damage. There is microglial activation, and it's, of course, one big neurodegeneration. Lupus is an induced autoimmune attack on connective tissue and DNA, mainly affecting kidneys, joints, vasculation, brain. In lupus, we see that mainly young women are affected. Early 20s, early 30s. It's usually after puberty. But the diagnosis is very difficult because the presentation can be very variant and the symptoms are atypical. It's difficult to diagnose, really. Now, primarily, we have an overactivation of B cells. Immune complex is being formed and deposited. We have a situation where Th1 is deficient and Th2 is dominant. Remember, balance Th1, Th2, cellular immunity, antibodies. In these situations, it's not imbalanced, but Th2 is dominant. And inflammation with more production of cytokines. And there is a release of nets, neutrophil, extracellular traps. You can compare it with some kind of spider webs that cause damage. Well, actually, I see some slides are missing. Okay, the slides where I discuss the symptoms we see in lupus. So, oh, yeah. So, yeah. So the slides you have are the correct ones. Okay. Good to know. So the clinical symptoms, joint pain, cutaneous manifestations like rash and photosensitivity. Renal failure in our lupus patients, we see easily in 50% of our patients renal problems. And also neuropsychiatric problems like confusion, anxiety, and cognitive dysfunction. Now, other clinical symptoms, but more based on the clinician's experience, are an history of growing pains. As I told you before, we usually diagnose after puberty, but even though we diagnose after puberty, we see these growing pains, this teenage migraine, and prolonged glandular fever, often before puberty. Also, often in lupus patients, a severe reaction to insect bites. Th1, Th2 is not so well balanced, so also over reactions in this perspective. Often miscarriages, and also something very typical we see in lupus patients is agoraphobia and claustrophobia. Okay, now let's discuss the causes and the contributing factors. Autoimmunity, but also multi-infectious disease. First of all, vitamin D3 deficiency. Vitamin D3 is very important as an immunomodulator. Deficiency in vitamin D3 will not only increase the risk to develop autoimmunity, but will also increase symptoms. This is a great study in MS patients. It's important to know that high doses of vitamin D3 are used in the studies, are required. In this study, we use 40,000 units a day. So that means that we achieve a peak blood level exceeding 400 nanomole. Usually, in vitamin D3 therapies, let's say 100 nanomole is more acceptable. But even if we use these high doses, we see no adverse effects in this study. Vitamin D3 is pretty safe. And as a result, we have a general improvement of symptoms and also the improved regulatory T cell function. In lupus, in our lupus patients, 85% of our lupus patients are deficient in vitamin D3. In this study, published in 2012, we use high doses, but not so high as in the previous lupus study. Here we use 100,000 units a week in the first period, and then 100,000 units a month. What is, let's say, more probably acceptable for a lot of doctors than what we used in the lupus study. And also we see a general improvement of all symptoms and an immune response that is better balanced. Gut, microbiome and diet. No wonder gut and gut system are involved, because 80% of our immune system resides in our gut. We have more neurotransmission in our gut than in our brain. And automatically, everything that is inducing changes in microbiome could also induce our immune response. So, for example, changes in microbiome induced by changes in food, or stress, or hormonal changes, toxins, sleep, could produce more inflammatory cytokines, and as a result, immune balance is disturbed. Gluten sensitivity. Gluten sensitivity is very common in autoimmune diseases, in multi-infectious disease, in neurodegenerative diseases. Gluten, but also casein, damage the epithelial cells, and as a result, we see leaky gut, but also leaky blood-brain barrier. Very common in the situations we are discussing. Dr. Fasano is a very well-known researcher from Harvard with a great international reputation. He states that in these patients we are discussing, gluten intake equal damage, leaky gut. So toxins and pathogens can easily cross the lining, activate our immune system, and cause autoimmunity. Now, in these situations, what we like to consider as scientific-based treatment options, because I'm not only discussing the facts, I also like to show you possibilities, but scientific-based. First of all, we should mention glutamine. Glutamine is fuel for intestinal lymphocytes. If we give more glutamine, the intestinal lymphocytes will produce more secretory IgAs, and the secretory IgAs are the antibodies that form the barrier between gut and circulation. They decide what will enter the blood circulation. Now, if we administer glutamine, we will repair the lining with secretory IgAs. And the preferred forms we use in our therapies are pure glutamine in powder without any additives, because you know that a lot of patients have problems with the additives. Or another development, it's the glutamine in a coating. And this glutamine coating releases the glutamine at the pH 7, and this is exactly the pH zone where the problem is located, at the end of the end of the small intestines, yes, and the start of the large intestines. Now, as a treatment option, beside glutamine, I also think the use of probiotics is very important to repair the lining. And I see in our developments, in our studies, that we are more and more using soil-based probiotics instead of milk-derived probiotics. Based on last publications, on studies, we see that the soil-based probiotics give very good results in inflammatory situations, even in infections. Now, the soil-based probiotics are more resistant to stomach acid than the milk-derived, and they colonize better in the intestines. So I think it's certainly an option that we might consider. as a third treatment option. It's not on the slides, so I'm just giving you some practical input. So the third option, beside the glutamine and probiotics, are extra stomach acid, diluted stomach acid, because we see in a lot of these situations that we have a deficiency in stomach acid. And stomach acid is very important. We need stomach acid to break down our food, to digest, but we also need stomach acid to activate our pancreas, to release the pancreatic enzymes. And of course, last but not least, the stomach acid will also make sure that we have the correct pH, that some harmful bacteria will not develop and cause SIBO, small intestinal bacterial overgrowth. So glutamine, probiotics, and stomach acid. Diet. So I think it's clear that I would definitely consider to avoid gluten. Another molecule or another kind of food that I always prefer to avoid is sugar. And why sugar? Because just as gluten, it's pro-inflammatory. Sugar raises our blood sugar level, causes glycation, and glycation is linked with oxidative stress, damage, and autoimmunity. Okay. We see in many situations hormonal imbalances. Low testosterone level in men and women means higher risk to develop MS and autoimmunity, and the disease will be more progressive. If we, based on the lab results, if we optimize our testosterone levels using bioidentical testosterone, we can improve the situation, and we see even the regeneration of the myelin sheath. But it needs to be bioidentical testosterone. So, and the only way to administer bioidentical testosterone in men and in women, because also in women it's useful, but you just need to focus on what you measure in the analysis, and based on this result you can just supply and optimize the dose. Well, the only form that you can use in this situation is transdermal application of testosterone. It's the only way to make sure that it's bioavailable and that it's absorbed. We also see low level of testosterone in lupus. And also in many studies we see improvement after administration of testosterone. But on top of that, in our lupus patients, we often see higher estrogen levels, even if in our male patients. So if estrogen is really sky high, we might consider even to use aromatase inhibitors. They block the conversion testosterone to estrogen. We have some drugs, some registered drugs, but also some nutritionals with good scientific-based evidence. Adrenals. Adrenals are always involved. In our patients, we see what we call adrenal fatigue. Levels of adrenal hormones are low. And as you know, adrenal fatigue is always the second stage. In the first stage, we have adrenal stress. We produce more adrenal hormones till the hippocampus says it's been enough, and the hippocampus gives a negative feedback to our adrenals. Second stage, adrenal fatigue. The clinical symptoms we see in adrenal fatigue are exhaustion, more emotional reactions, sometimes dark circles under the eyes. Now, based on our lab markers, we can optimize our adrenal hormones. Optimizing DHEA levels is very common in autoimmune pathologies, in lupus and in MS. And we see in both situations better results and less severe symptoms if DHEA levels are optimized. Now, bioidentical DHEA can be administered as an oral form. You don't need to go transdermal. Thyroid hormones. Thyroid hormones are also important immunomodulators. So if you are low in thyroid activity, it will be more difficult to modulate Th1, Th2. Low levels of thyroid hormones, higher risk to develop autoimmunity. But in the second part of the presentation, we will focus more on thyroid complications. Of course, toxicity. Toxicity is always a contributing factor in autoimmunity. Heavy metals, plastics, pesticides, PCBs, the list is endless. We see a higher prevalence to develop autoimmunity if we have more toxicity. Now, development of autoimmunity will often depend on the quality of our detoxification system. We have our own detoxification system, and it contains two phases of two stages, let's say. In a first phase, we transform the toxin, and in a second stage, we conjugate another molecule, a self molecule, I should say, like glutathione or glucuronic acid, and so we make a water-soluble compound that we can eliminate. That's how we detoxify. So, and if this system is working well, then we will accumulate less toxins. This is how it works. Now, we can improve this system if we supply more glutathione, more of this conjugate to form water-soluble compounds. But the problem with glutathione is that it's poorly bioavailable. The only way to make sure that it's well absorbed is to use IV glutathione or oral liposomal glutathione. These are the only forms that are well absorbed. Now, facing glutathione, yes, I think on your slides you have the graphs showing, these are the data from a study we've conducted last year showing the bioavailability of glutathione. And these data are data we collected after 2 weeks of treatment with oral liposomal glutathione. We call it our Trifortify study. And in this study, we see that after 2 weeks, the levels of glutathione in red blood cells are increased with 27% after 2 weeks. And also our natural killer cell function is improved with 152%. So glutathione works on different levels. Improved detoxification, improved immune response. And it's also interesting to know that glutathione is also a powerful antioxidant, so less damage from free radicals. And if we go even further, focusing more on Lyme, using glutathione, or just using glutathione every day, we will have more severe, or less severe, excuse me, less severe Hoech's reactions. So I think we have many reasons why we could consider to use glutathione. Another molecule that might be interesting also on the level of decreasing the neurological damage is alpha-lipoic acid. Alpha-lipoic acid is a powerful antioxidant, and it's one of the few antioxidants that is able to cross the blood-brain barrier. And because of that, we see studies with alpha-lipoic acid in MS. Usually, the standard dose we use in studies is 2 times a day, 600 milligram. Biotin. Usually, if we use biotin, we use doses of 1, 2, 3 milligram. But in this study with MS patients, we are using very high doses of biotin, 300 till 600 milligrams of biotin. And we see less damage in MS. Great studies and great results. In this study, we have less than 10% of patients who didn't improve after 3 months or after 6 months. So I think it's a pretty good result, considering that biotin has no side effects. Melatonin, but I think on your slides you also have molecular hydrogen. Is everyone seeing molecular hydrogen on the slides? Yes. Yeah. Well, molecular hydrogen is also one of the newest developments. It's a very powerful antioxidant, and the advantage is it's odorless, it's tasteless, it's colorless. It can penetrate every biomembrane, and it can also, of course, cross the blood-brain barrier. So in studies, we saturate water with molecular hydrogen. Of course, you need to close the cap to make sure that it doesn't escape. And we see great results in different conditions with neurological damage. Melatonin. I like to work with melatonin, but definitely in autoimmunity, you need high doses of melatonin. Melatonin is a very powerful immunomodulator, Th1, Th2. We use it in autoimmunity, and, but we even use it in cancer treatments, but always 20-25 milligram. In our studies with MS patients, we see that the blood-brain barrier is being stabilized. Other reasons why melatonin are useful in our therapies are the fact that melatonin is also important for the circadian rhythm, I should say the symphony of all hormones. So melatonin, for example, promotes growth hormone, very important in recovery. And melatonin even promotes the conversion T4, T3 in thyroid metabolism. And on top of that, of course, melatonin will improve the quality of sleep and the recuperation during sleep, what is, of course, also very important in our patients. Now, scientific options to restore this Th1, Th2 balance. LDN. What is LDN? Low-dose naltrexone. We know naltrexone as a 50 milligram tablet that is blocking opioid receptors in competition. So that means that we use naltrexone in its 50 milligram form in treatment of addiction, all kinds of addiction, alcohol, opioids, and so on. Now, the properties I would like to discuss today are totally different. But LDN is blocking the same opioid receptors, so the low doses we use are blocking the opioid receptors, but only briefly. And if we briefly block opioid receptors, we see a mechanism with upregulation of our own endorphins, and our own endorphins rebalance Th1, Th2. LDN, low-dose naltrexone, doses between 1 and 4.5 milligram, has been introduced, I should say, in treatment of HIV patients long ago to prevent the destruction of immune system. And in the studies, we measured the progression of CD4 natural killer cells. But this was the official introduction of LDN. Now, LDN is used in many studies, MS and lupus patients, rebalance Th1, Th2. On top of that, LDN is also very important to decrease some symptoms we often see in our patients. Because LDN is not only briefly blocking the opioid receptors, it's also blocking toll-like photoreceptors in our, I should say, periphery. Because of that, we will develop less inflammatory cytokines, and LDN is, as a result, very useful in peripheral neuropathy complaints like numbness and tingling. I think that we often see these peripheral neuropathy symptoms in our patients. But there is also a central activity, blocking the microglial activation, and as a result, we see neurologic symptoms improve, like cognitive dysfunction, pain sensitivity, and sleep disorders. So rebalancing Th1, Th2, but also really focusing on some symptoms like peripheral neuropathy and neurological symptoms. Yes, I think you have another slide with the first slide is some kind of graph, let's say a summary of the pharmacology I just discussed with you. And then the next slide is, I think, very important to make sure that, that we know how to use LDN. Some practical details. When we say low dose LDN, we mean a dosage between 1 and 4.5 milligram. Usually we start very low with 1 or 2 milligram and we gradually increase the dose. And pure in our studies, statistically seen, usually it's 4.5 milligram as an optimal dose. The daily administration is at night, 8 or 9 o'clock in the evening, and the only side effect we see are more vivid dreams. But it's only temporary. Now, if you have the feeling that these more dreams really disrupt the quality of the sleep, then you might consider to administer the LDN in the morning instead of the evening. It's acting on opioid receptors, so never combine LDN with drugs like codeine or tramadol. If patient is on these kind of painkillers, you should respect a washout period of 10-14 days. Find a compounder who is able to compound LDN from raw, pure material. It's impossible to prepare good quality LDN by smashing a 50 milligram tablet into pieces and giving this to the patient. Really, the quality we need in our treatment should be as good as the quality in the publications. And then we can really see the same results. It's also important to know that this therapy is even safe during pregnancy. Another option to optimize Th1, Th2, because this is the main problem we are discussing today, is the use of transfer factors. Now, transfer factors are messenger peptides, and they improve the communication between immune cells. No. Back to the slides you have received. Well, transfer factors make sure that immune cells have a better communication, and as a result, immune balance is guaranteed or better guaranteed. We have great studies with transfer factors. Showing an improvement of the natural killer cell activity with 248% even after 1 month of treatment. And considering transfer factors, it's important to know that we can even have very specific treatments, because based on the infections we see, it's possible to target some specific co-infections or even reactivating co-infections. Okay, then thyroid disorders, autoimmune thyroid disorders. Autoimmune thyroid disorders go often hand in hand with multi-infectious situations. Now, how is our thyroid system supposed to work? Well, the hypothalamus activates the pituitary. Pituitary activates thyroid glands. Thyroid glands, as a result, will produce T4 hormone, and T4 hormone needs to be converted into T3, the active form. This is how the thyroid system is supposed to work. Now, poor thyroid activity should always be diagnosed based on the symptoms and based on the lab results. It's impossible to have a good diagnosis just by checking lab results or just by checking symptoms. We need both. Now, what clinical symptoms do we often see in reduced thyroid activity? Depression, higher cardiovascular risk, myxoedema, very typical. Situation before thyroid treatment, situation after thyroid treatment. So we call it, in the first stage, a deposition of connective tissue. It's what we often see. It's also one of the basic indicators that thyroid activity is not as it should be. Other typical symptoms, if thyroid activity is not optimal, is of course overweight, increased sensitivity to cold, even if temperature is pretty normal, and slowness, apathy. The activities, everything is getting slower. Swollen eyelids, especially in the morning, dry skin, infertility, all symptoms we see in poor thyroid activity, but also a sleep that is unrefreshed, always fatigued. Also common in our patient is the yellowing we see in hand palms and soles, and a delayed Achilles tendon reflex and knee reflex. Constipation, very common in poor thyroid activity because T3, the active thyroid hormone, activates the release of stomach acid. So if we have poor thyroid activity, we will have a deficiency in stomach acid, poor digestion and constipation, very common in hypothyroidism. But also brittle nails, hair loss and keratosis on elbows. Hoarseness in the morning, decreased cellular immunity, and also decreased mitochondrial activity with fatigue and cognitive impairment. Now, let's discuss both most common autoimmune thyroid disorders. The first one is Graves' disease. Typical symptoms are goiter and also bulging eyes. On your slides you have an additional picture that is not on this presentation. It's a picture of Marty Feldman. For me personally, one of the most known patients suffering from Graves' disease with typical bulging eyes. Hashimoto. In Hashimoto, we have antibodies destroying the thyroid glands, causing hypofunction, causing hypothyroidism. Now, it's important to know that in all chronic inflammatory states we are discussing today, multi-infectious disease and autoimmunity, we have reduced cellular levels of thyroid hormone, even if lab markers are normal. So it's important to know that TSH, T4 and T3 often fail to detect hypothyroidism. So good observation of the clinical symptoms is very, very important. Don't rely only on your lab markers. Now I think, yeah, this one. I'm happy it's I found it because it's a very important one to explain you how the system works. This is the situation we have in multi-infectious disease, in autoimmunity. On cellular level, this conversion T4, T3 is always decreased. So we have poor levels of T3. Yeah? There is more production of reverse T3. And reverse T3 is the antagonist of T3. So this is the situation we have on cellular levels, on cellular level. Now, in our pituitary, in these circumstances we are discussing today, well, the conversion T4, T3 is increased. So in our pituitary, we have a perfect normal T3 level. So even though our cellular levels are really below normal, we have normal TSH because the situation in the pituitary is not reflecting the situation on cellular level. What are the treatment options for thyroid disorders? We need a multifactorial approach. So don't just look at the thyroid, but look at the complete system. Integrative, functional approach are necessary. So take care of the immunity, the gut, adrenals. Make sure you decrease inflammation, upgrade detox. T4 is often a poor treatment choice. We need T3. T3 is the active form. So as an alternative, we have combinations T4, T3 from natural origin, from ERFA or Armour thyroid. Or we even have, in France it's registered, we have T3 Cynomel, especially in situations with high levels of reverse T3. But of course also LDN. LDN in these thyroid disorders to rebalance Th1, Th2, better transport of thyroid hormones on cellular level, better conversion T4, T3, and less reverse T3. So, as a conclusion, autoimmune diseases are sometimes induced by infections. There is never one cause, but it's usually a combination of factors, as we discussed. So we need extensive testing. All risk factors should be minimized, diet, toxicity, and so on. And of course, we need an integrative approach. We need to restore all systems. Thank you. I'm sorry for the confusion I created with the slides and the papers. So if you have more questions.
When you talked about diet, you said about gluten-free and sugar-free, and then on the slide it said about saturated fats, but you didn't talk about saturated fats.
No. Well, I think it's important to know that, you know, in some studies, with, particularly with MS, we see that the unsaturated fats and even fats are useful in diet. So it's not that I'm saying that fats should be completely avoided in all autoimmune diseases. We need to detail and make sure that we have the correct diet for the correct disease. So let's say what I should advise in MS is slightly different than, for example, in lupus. But we all know that saturated fats are pro-inflammatory. Remember the benefits we see with omega acids, with the balance omega-3, omega-6. So I think this is something we need to respect in autoimmunity, but also in all kind of inflammatory and chronic diseases. To decrease inflammation is one of the main targets, and this is probably also why we often use good quality fish oil in larger amounts, because it is anti-inflammatory, less cytokines, less prostaglandins and leukotrienes will be formed. So I think saturated fats should be avoided, but this is according to the basic knowledge of omega-3, omega-6 being beneficial and everything that's saturated being not beneficial.
You mentioned SIBO. Is SIBO treatable? How would you?
Well, SIBO, of SIBO. I don't know how they pronounce it here in England. SIBO, yeah. Well, SIBO is the situation where our gut bacteria get out of balance, and very harmful bacteria have the chance to develop more than they should. And it's often linked to disturbed pH, disturbed acidity in our gut. A typical situation that we see with SIBO is, for example, patients chronically using proton pump inhibitors like omeprazole and pantoprazole. In these circumstances, we create almost the same. So based on disturbed pH, disturbed acidity, we mess up the complete balance between bacteria in our gut, and in this dysbiosis we create an inflammatory situation, sometimes so severe that we need to use antibiotics with only local activity in our gut if it really gets out of balance. Now, to be complete, I would prefer to start first with rebuilding the system, as I discussed during the presentation, with glutamine, good probiotics, and betaine. Well, personally, I prefer to use diluted chloric acid, because if you use betaine, often betaine together with pepsin, well, in this situation we need to convert the betaine into chloric acid. Yeah? Administration of diluted chloric acid, let's say, is a more bioavailable system, and we also have the advantage that we can really use the optimal dose. You can start with 1 drop, 2 drops, 3 drops. So the dose is really depending from patient to patient, and you can really balance the exact dose. It's more convenient and possible with drops than with capsules, because in capsules, betaine, you will always have a standardized dose and a standardized formation of HCl. So personally, I prefer the diluted chloric acid together with pepsin.
With melatonin supplementation, that people argue that that stops the body actually producing melatonin
I'm sorry, melatonin.
Yeah, sorry. Yeah,
Melatonin, yeah?
Yeah, that if you use a supplement, that actually stops the body producing it itself, and that's an argument against using a supplement.
I think it's a very good question, because using, let's call it bioidentical hormones, we need to make a difference between some hormones that will automatically diminish our own production, like, for example, adrenal hormones. If you supply bioidentical cortisol, you need to take care, and I always advise it in short periods, because your own production of cortisol will automatically fall down. In melatonin, I think we need to consider that when we grow old, automatically we all will produce less melatonin. And we see in low doses that we will disrupt the own production. But it's a fact, it's something you need to consider in the different hormones. Be careful, use the correct dose. But in melatonin, it's something that we can use in every patient. For example, using 2 or 3 milligram melatonin is even the best or one of the best anti-aging formulations that you can imagine. Pardon?
Sorry, for children.
For children, well, I don't have data with melatonin treatments in children, so I don't have information or data on that.
Have you found that using just T4 on its own is harmful, or just doesn't give the best result?
Well, everything is really depending on the situation. Let's say purely based on the lab markers, if we have the results of TSH, T4 and T3, we can partly see where the problem is located, because as I showed you in the picture, it's a system starting in our brain, hypothalamus, pituitary, adrenals. So the problem can be located on different stages. And sometimes in some patients we have a deficiency in production of T4. And in these patients, of course, we need to administer T4. But if you see, like the situation that we've discussed, if we have a deficiency on cellular level, like we have in autoimmune diseases and multi-infectious diseases, then T4 will probably not be sufficient, because we also need to convert T4 to T3. And if this is not optimal, then the treatment will not be successful just by using T4. In these circumstances, you need a combination. But, you know, treatment of thyroid disorders is pretty complicated. You have the clinical symptoms, you have the lab markers, and you start with the treatment and follow up also based on the results you see and the patient is telling you, and based on this information you can really optimize and find the really balanced treatment you need. But in these circumstances, yeah, you will need also T3.
Just a little remark. In the UK, any doctor who prescribes T4 plus T3 is being struck off.
Well, it's not only in the UK. I think even in Scandinavian countries, it's not allowed. Yeah. Well, you know, I give my presentations everywhere, and of course I show data and I show what's needed. But I know politics are different in every country, and sometimes what I show in my presentations is not immediately available. Yeah. Well, maybe because of this data, because of these sessions we organize like today, maybe someday those treatments will be available, because we have more than enough data to show that we need those treatments.
I took low-dose naltrexone and it made me fall over. Ridiculous to say. In other words, if in a normal course of a day you might trip and restore your balance, when I took the LDN, I couldn't restore the balance and I'd fall. Is there any particular reason for that?
Well, and what dose did you take at the start?
It would have been a low dose.
Yeah, but was it immediately 4.5 milligram, or was it less? Because usually we never start immediately with 4.5 milligram, because the situation and the patients we are discussing today are very sensitive patients. So we have very many patients where we need to start with 0.5 or sometimes less, and gradually we build up and we end up with good results. But I need to tell you that the improvements we see with LDN are always improvements on different months, and sometimes you need even more. So it's important to go very slowly and to make sure that you don't manifest side effects like you have, or let's say that there is no increase of symptoms, neurological symptoms. And if you consider this situation, I would definitely say, well, let's start again with a lower dose, much lower dose. But in many situations, not only autoimmunity, but also neuropathy complaints, we have seen great results with LDN, results that we could not have got with other treatments. So sometimes it's practically the only, I would say, magic bullet we have. But every patient is different. Many patients are very sensitive, and in these situations, lower the dose. Eventually, at the start of the treatment, take one dose every 2 days. This is a balance that needs to be found in every patient differently. There is no standardization of this kind of treatments. Everyone is different. Doctor?
Going back to SIBO, would you ever test stomach acid output?
You mean testing really how much stomach acid is being produced?
Using a manometry or Heidelberg test?
It's possible, but more conventional are, for example, breath tests. When so you administer carbohydrates to the patient and you measure the fermentation. So this is, I think, a method that is also in the UK used, and you can measure pH. We have some methods. I think one method it's called the Heidelberg method. I think
Heidelberg test.
Yeah. And but it's expensive and it's difficult for clinics to have this method. So I think the breath test is better, and of course stool tests where you measure the quantity of H2S sulfate gas and other molecules that have been produced by the harmful bacteria.
I wanted to ask a follow-up question about stomach acid, because we need stomach acid to digest protein.
Yeah.
And I've noticed amongst a small group of friends who have suffered acid reflux problems, have been given proton pump inhibitors without a test for stomach acid output, and also seem to suffer from joint problems, particularly of the spine. A number of them are having to have joints of vertebrae fused together to overcome problems.
So you mean patients using proton pump inhibitors?
Yes.
Yeah. Well, I think it's a fact that we should do something about the fact that too many patients are using proton pump inhibitors, because all the side effects we see, and the side effects can also explain what you see in your friends, because basically if you take away stomach acid, you will decrease the absorption of essential minerals like B12, like magnesium, like calcium, so much higher risk to develop osteoporosis, but also with the B12 much higher risk to develop dementia and cognitive problems. So this is also something I like to mention in other presentations. You know, sometimes we are focusing very hard on Lyme or autoimmunity, and we look for some specific markers, but I think it's important in all analysis that we don't forget to focus on the essential lab markers. It's stupid, I would even say, to search for reasons for cognitive impairment if you have not measured B12. And because if B12 is too low, well, start with optimizing B12 and then we can go on and see if there's an infection or something else. But the use of proton pump inhibitors is on the long term certainly dangerous, and it's also the best way, for example, to induce SIBO. For example, also spastic colon. 70% of those patients have SIBO. So usually it's really it's all going back to the basics. Restore the system. Doctor.
Well, thank you very much for your talk. I wanted to ask what your experience is of using iodine for patients, because we find it something that is often deficient in this country. In the diet, it's deficient.
Well, usually it's a geographical problem. We see some areas where practically the complete population has iodine deficiency. For example, in different parts of Russia, and but even not so long ago in Switzerland. Usually the areas or the countries where people don't often eat fish or seaweed, because it's important to know if you want sufficient levels of iodine. Well, the only sources we have, except of course the nutritional and the vitamin sources, are fish and seaweed. It's not enough to go to the sea and to and to breathe. No, we need really to consume iodine. And I think it's a very important and a good question, because I could talk for hours of this problem, because we see that iodine deficiency is not only in Lyme patients, statistically in 25% of the Lyme patients, but let's say in women population, iodine deficiency gives higher risk to develop breast cysts and breast cancer. So supplying iodine, vitamin D3, vitamin B12 are more and more essential molecules that should be given to everyone. Also in prevention, to prevent all these kind of complications we are discussing.
I went to see my diabetic nurse about 6 months ago, and I just mentioned to her that I like eating ginger biscuits, and it helped me sleep. And her explanation was that ginger helps the immune system. Could you elaborate on that? Is she right?
Well, you know, ginger, I think ginger has a lot of activities that have been studied, but to really focus on specific activities, we need the specific molecules we find in ginger. And the problem is, you know, in ginger tablets, I can't, and no one will tell you how much active ingredients there are exactly in these tablets. But, you know, ginger is, the main use of ginger is that it's improving our digestion without any side effects. But ginger and some active ingredients especially have also a very powerful anti-inflammatory activity. And so I don't know, depending on the quality of the biscuits, maybe they are just highly dosed in this active ingredient. But there are really different therapeutical possibilities with the active ingredients we find in ginger. That's true. It's a very healthy and useful natural molecule.
Can I just say, the English ginger biscuit is full of sugar. So, for somebody in that case, maybe a ginger tea before he goes to sleep.
And probably gluten also. Yeah, okay.
With autoimmune, would you ever look at dental health, and in particular root canal teeth?
With
root canal teeth?
Yeah.
When you look at autoimmune conditions?
You know, I think first of all it's important to tell you what we've discussed today are probably only a part of the contributing factors. I think I mentioned toxicity in all its different possibilities, and I think the fillings and the amalgam fillings and all the heavy metals that could be used in mouth could be very dangerous and could induce autoimmunity. And the molecular system behind this is the fact that heavy metals, are never free agents in our body. They jump around, they look around, and they bind what we call thiol group. It's sulfur groups that we have on some proteins in our body, and so they change proteins in our body, and as a reaction we will produce an autoimmune reaction against these proteins. So all heavy metals can induce autoimmunity that way. And don't forget that on top of that, heavy metals also cause demyelination. So what we are discussing, for example, in MS. So it's a story of many different contributing factors. And you know, in some patients we will sometimes never see any problem caused by that, and in other patients we really need to take away all the positive causes that might increase the severity of the autoimmune disease.